Is Dr. Arzubi joining today too?
He may or may not. He may just be a little late. We were just in another meeting, so I'm not exactly sure.
Perfect. Well, hello to the rest of you who are joining. We are just going to get started here very quickly. Just waiting for the rest of them to hop in our webinar here from the waiting room. All right. And as most of you can see, I do have a disclosure statement for today for continuing nursing education credits. So for those of you who will be obtaining those credits, this is the requirements that you do attend 45 minutes to obtain that 0.75 hours. And we are giving partial credits for those of you who can only stay on for 30 minutes. So it'll be 0.5 credits. So again, thank you all for joining today for the TikTok webinar. This is session 2 of 10. And again, we are offering nursing contact hours, and the disclosure statement is listed up here on the screen. These sessions are also being recorded, and they are available on our Mountain Pacific website. And so the next session will be on December 16th at 3 p.m. Mountain Daylight Time. So for those of you who only maybe selected this one, you can go back to our website, and you can also link that so it gets on your calendar for December 16th. There will be polling questions that we'll bring up during the webinar, as well as a link to the evaluation. It'll be placed in that chat box towards the end of the webinar. You will have the ability to unmute yourself, but please keep yourself muted while the presenters are speaking. And we will have time for questions and answers at the end. So feel free though to put in your questions and comments during the webinar in that chat box. So now I want to introduce our speakers, and just wondering if Dr. Arzubi is joining. He'll be away.
It'll be me speaking today anyway. So
okay.
If he doesn't,
okay.
Make it.
So we have Dr. Reza Gomi today. Dr. Gomi holds a BS in computer engineering from Rensselaer Polytechnic.
Rensselaer, yeah, it's really hard to say.
Thank you. Polytechnic Institute, a MSc in biomedical engineering from Johns Hopkins University, and an MD from the University of Massachusetts. He completed a residency in psychiatry and a fellowship in movement disorders and behavioral neurology at the University of Washington. He currently practices neuropsychiatry with a focus on cognitive, memory, and movement disorders. He is also active in engineering and clinic research, focusing on using advanced technology such as voice recognition to track and monitor treatment of neuropsychiatric diseases such as depression, schizophrenia, Alzheimer's, and Parkinson's disease. So thank you, Dr. Gomi, for joining us today. So I will open it up and stop sharing so you can share your screen, Dr. Gomi.
Wonderful. Can you see that okay?
Yep.
Wonderful. Hi, everyone. Yeah, thanks very much for having me. It's been great getting to know the Mountain Pacific team and being able to team together and bring you some educational opportunities. I didn't say too much a couple weeks ago when Dr. Arzubi was speaking, and I'll be teaching the bulk of what's left in this series. There's 9 more parts, and one of my goals is to make sure they're obviously linked together. So, and I really do like interruption and active participation. So please do it. Obviously harder with Zoom. If we were in a room, you guys would hate me because I would force you to say stuff. But I will. Maybe I'll even look at the participant list and just call out random names. But the idea is for these talks to be practical in nature. We're going to give you data. We'll give you all the the usual stuff, but we really want to motivate you and empower you to feel that you can take some of this and put it into action in whatever your work setting is. And this is geared towards anyone that works in any nursing home setting that is patient facing, taking care of people at any level. So we will get into some medical stuff later in the series. We'll get into some psychological stuff, but it's really meant to be accessible for everybody. And so today we're going to focus on primarily a project we did with the Montana Mental Health Nursing Care Center. It's a mouthful. We refer to it lovingly as Lewistown because that's where it's located and it's easier to say. And they're actually a pretty impressive resource. I'm not aware of a lot of states having this, and I know we have people from Hawaii, Alaska, Wyoming, and Montana on the call. Let me know if your states have these. In Washington, where I live most of the time, we don't have a center like this. And this is a state level, state funded, just like the state hospital. Under that same umbrella, they have a actual nursing care center. So it tends to be people that have longer term mental health or behavioral issues that will need long-term placement. So it's a wonderful resource for the state. They do a great job. And so I hate to say, but in Washington, a lot of these are the kinds of patients that unfortunately end up homeless or, really don't have many options. So this is really valuable. So we were very, very excited that we have been able to provide them telepsychiatry. We're actually coming up on almost a year now. And so we did a bit of a quality improvement project. I want to share some of that with you all and then just kind of see what you think. And hopefully you'll have some lessons to take away from this. And this is obviously going to have the bent of looking at it as a psychiatrist, but we want to tie in other opportunities as well for improvement. Just in the way of, let me see if this is going to work for me. Yep. In the way of disclosures. So just keeping in mind, of course, we all have biases. And so, being upfront about my internal biases, which I try to do my best to be aware of, the Frontier Psychiatry Group, which I'm a part of, I'm, one of the partners, one of the owners. So I have, certain opinions about how telepsychiatry should be delivered. So take that with a grain of salt. And I'm also an employee, very part-time employee of BrainCheck, which I will mention later. The reason I mention that is because I do have, we are using their cognitive testing. It's a computerized cognitive testing platform, and we have implemented that at Lewistown as part of our improvement. So I'll talk a little bit about that as well. This is the only slide with this much text on it, I promise. This was just a few slides to recap what we talked about 2 weeks ago with Dr. Arzubi. What are we doing here? We're really thinking about this trauma-informed care. So the idea is, how do we help provide care in the nursing home residential setting while taking into consideration someone's past, and the kind of being they are, beneath whatever the diagnosis is, right? And so we're pointing out, Medicare and CMS has really made some of this required, but of course, tracking it and knowing if it's happening is a whole nother story, right? We're all used to seeing requirements come down the pipeline, and it's up to people like Mountain Pacific coming together to help us figure out how to actually do this. So we're in that kind of position of, okay, this is a new requirement. It's very new. It's only a year old. How do we actually put this into practice? So the whole point, and this is what Dr. Arzubi went over a couple of weeks ago, the facility must ensure that residents who are trauma survivors receive that culturally competent, trauma-informed care. He mentioned, just to review quickly, he focused on childhood adverse experiences, a child ACEs study, adverse childhood experiences, and went over the different types of traumas to think of. It's really easy for us sometimes to default to, specific type of trauma, physical trauma, maybe emotional neglect, physical neglect come in. But it's, you have to keep in mind, for all of us, we all react differently to various events. And so whether ourselves or a family member had substance use issues, experienced a divorce, if there's household dysfunction, often that is a big driver of later outcomes. We know incarceration has a big effect. And so we discussed that a couple weeks ago. The lasting impacts it has. Much of those childhood experiences go on to increase the likelihood of all of these issues, whether they're health issues, cancer, diabetes, whether they're substance use, behavioral issues, depression, anxiety. And these all translate into behaviors I'm sure all of us watching right now have seen in person, in really working with patients directly. And so their coping skills are all going to be fueled by these childhood experiences. And the majority of the time, where our coping skills are the same ones we used that may have worked well for us as a child or as a young person, but have not translated all that well. And getting older, becoming more frail, losing resilience, brings out some of what we did when we were younger. So my area of expertise and interest is dementia. And so just pointing out, in the general population, right, who live with trauma, huge rate of risk increase for developing dementia if you have adverse experiences as a child. So we know, this is all correlation. We're not saying it's causative, but it's such a strong correlation that we see there's clear factors, and there's more research into going on into figuring out what that is. So I'm very motivated to help those with memory loss or sort of a neurological overlay or underlay, whatever you want to call it, that has to do with the behavioral changes. So I take care of a lot of different types of organic brain disease, but keep in mind, a lot of overlap neurology and psychiatry. So there's a lot of underpinnings of behavior we see in the nursing home community that might be related to specific dementia, but it might have had an underlying bipolar disorder their whole life. Now they have dementia. So there's a complex interplay there. And so let me jump into here. So we'll come back to where we get started. We'll actually come back to this where we're going to talk about how do we basically implement some new types of care or quality improvement efforts in the nursing home setting, or really in any setting. And so some of the questions we ask, Dr. Arzubi brought up last week, and I wanted to build on this, is leadership on board? Who's the passionate champion? What are we actually trying to do? What data are we looking at? We don't want to just grab data for the heck of it. We want to, pick carefully what data we want to track and then be able to measure that. Looking at what risk factors there are, protective and risk factors, and then being careful to know the individuals we're working with. We talk a lot about quality improvement. At the end of the day, we're working with individual people, so we love to put metrics out there, do averages, do statistics, but at the end of the day, we're talking about individuals. Here's a pop-up question now. So does your facility track quality measures that are tied to trauma-informed care implementation or processes? Go ahead and answer that. We have a chance. Now jumping into this real-world example we want to go over today. Lewistown, the nursing care center in Montana, the state nursing care center, their leadership really was the ones that approached us in the first place. So in a way, our job was already right off the bat a little bit easier because we had buy-in from the top. And so that made it a lot easier. I have to give a big shout out to Heidi Southworth and then Shannon DeLeo, really outstanding champions that were local there. And you can see the results from this little pop-up. So we got, of course, and that's completely expected. Remember, this is a pretty new direction we're going in, but 19% already is great. That's a good number to start with. So yeah, Heidi and Shannon have been outstanding. So that honestly made our path way easier. I've done quality improvement projects 15, 20 years now. And boy, what this was in terms of just ease of adoption was the door was open, let's put it that way. And so it made it a lot easier. They brought us in, they identified a need, and the need was being able to manage their patients, see a mental health professional more frequently, being a nursing care center, of course, to do some gradual dose reductions. They're listed here on the slide. So a number of visits with a psychiatrist, or in our case, it's a psychiatrist, but we do also have nurse practitioners, so it just depends. But with Lewistown right now, we have a psychiatrist that is managing and taking care of patients. Number of medications, psychotropics patients are on, frequency of gradual dose reductions, and patient and staff satisfaction. These are all things that matter to various stakeholders. Some of these are metrics that are tracked federally and by the state, and so they're more things we kind of have to do, but the reasoning behind them is what's important. And I don't know if some of you or all of you are familiar with gradual dose reductions, but in the mental health world, we have seen over the years people end up on medications for many, many, many years. And so there's a push to reassess and say, well, they may have needed this 30 years ago. Do they still need it now? So tracking how many of these gradual dose reductions we do is one of the indicators for how well we're caring for people. Now, I look at these as really playing to someone's independence and sense of, autonomy. This is really respecting a kind of a human being's individuality. And so, although these are federally required, state required, they're tracked. We're doing them. There's many good reasons, and I really like empowering patients by saying, you actually do have some control into coming off of medications and following through with that, right? And showing them that, because medications, especially psychiatric medications, have a lot of meaning. They kind of they can communicate that maybe they need it, there's something broken, et cetera. And so we want to change that conversation. And so our approach is very much strength-based. And so it's really taking into consideration from a trauma-informed perspective of what are those coping skills from childhood, how was that patient affected, now how do you play on their strengths and really empower them? Even with Alzheimer's at age 80, there really is no limit. Of course, at the nursing care center, there are some patients that are very, very disabled, but really there's surprise. Maybe some of us would be surprised, but there's quite a few that are very able to still do lots of things. So we jumped in. I'll jump into the data real quick. So what we did was we had the previous structure was an in-person psychiatrist that came once every 6 months to on-site. And so our goal was immediately to increase that exposure. We wanted patients to have more access. So after 3 months of our model, we compared to the previous 13 months of the in-person psychiatrist. So it's not quite apples to apples. I mean, all the data we had for ourselves, we did 3 months in. So we looked at number of visits by the psychiatrist per 60-day period to compare, number of psychotropics, number of gradual dose reductions, and then those satisfaction scores. And we use simple Likert scales for this. So we ended up chart reviewing 43 patients that we tracked from January 2019 through May 31st, 2020. So a total of 13 months there. And 9 staff also participated. So in terms of the patients, you can see, I just want to run through some of this data so you can kind of get an idea. And really what we were doing here, we were doing a few things. We were validating the use of telehealth technology in the nursing care center. Also in a facility where you traditionally might think it would be difficult. So this was a little bit of an experiment, but we wanted to validate that even if someone you think who traditionally might have difficulty interacting, has certain disabilities, may have difficulty, but really it went pretty well. You can see obviously the big change. The in-person psychiatrist, of course, we already knew was only coming once every 6 months. So we were able to drastically increase. So now we see that a single patient will see us at a minimum under 2 months. Every 2 months they'll see us at a minimum. So we've been able to increase that. This also comes from a trauma-informed perspective, because by having a more frequent interaction, we're able to get to know that person more. I actually started this relationship, so I was seeing the patients, and and now we have a long-term provider, because part of the challenge was in some of these settings, and what we're trying to address is provider turnover. And so either not seeing the provider often enough or provider turnover. Well, if you're already having struggles with mental health issues, if you have adverse childhood experiences, it's probably not that helpful to have a new person talk to you very infrequently, but just dive right into very difficult subjects. And so part of our goal is to build that relationship, really make a warm and inviting environment, and get to know the person. Remember, any questions, jump in, okay? And then the number of psychotropic medications we prescribed in just the first few months, again, it was only 3 months we were there, but we were able to already show, I wasn't expecting to see a difference, but we were already seeing the numbers drop. So we've been pretty, we're pretty young and hip. And so we like to just kind of reduce medications as much as possible. In my line of work, of course, focusing on dementia, the main thing I do is eliminate medications, because so many can really impair your thinking. So, things really switch gears as we age, especially if we have a history of mental health issues. Gradual dose reductions. This is a slide that makes the nursing home staff chuckle because being very patient with us. Of course, we're on telehealth, so it's a little. I joke with them that it's easy for us to stop at medications because we don't have to deal with the outcomes immediately. But it's taken a lot of. It's what's important about the collaboration and communication is hugely important here. You could argue maybe more important than being in person because I'm not going to be there on site to see the result immediately, whereas the staff do. So we rely on the staff. Luckily, the nursing care center uses a convenient texting app. And so we have a group and we can kind of hear from each other very quickly with changes. So it makes for a very quick response time, which is nice. But our goal is to, of course, reduce number of medications, especially as the patients age. And these are just some of the numbers. So in number form from what we just looked at visually. So the number of visits per 60-day period, the psychotropics, and the gradual dose reductions. We then went through, lo and behold, we were able to wrangle some answers from residents. So some of the actual patients there went through and answered some of their satisfaction questions. These are some examples. And so, and here's kind of how things came out. And, honestly, better than I expected. Going into this, personally and others had a lot of concerns, and for good reason. But again, and we were lucky. We started this right before COVID started. So, to be frank, COVID has almost made it a little bit less of, made pushback a little less because there's fewer options now for in-person services anyway. But so it's a little bit of a bias because this kind of straddles COVID a little bit. So if COVID hadn't happened, I'm kind of wondering in the back of my mind if people would be less satisfied, but just throwing that out there as a consideration. Now, patients overall were satisfied or very satisfied. A few, there was one patient in particular who was very dissatisfied. That was funny when I saw this result, I knew exactly who it was, as we often do. How do you rate the technology? I could see the psychiatrist as well as if I met in person, people were generally pretty satisfied with that. Again, we want to make sure that for for some of the people staying there, this technology piece we can look at as a big barrier. It can be hard to establish rapport. So it's a lot more, it's important for me to do some purposeful but careful disclosures, and create a warm environment. Sometimes I have my dog will be running around, so my dog will jump up and say hello. It's things like you really got to make sure, being on the video side of it, they know I'm a human. I'm here because I care. I'm really trying to make a connection, even though I'm not there in person. How do you rate the quality of care delivered when compared to in person? And overall, it looks like it's pretty even. Not seeing a big difference. Comfortable during the telepsychiatry consultation. People were definitely more comfortable than I thought they might be. The staff at the nursing care center were wonderful with helping us adjust the environment. We ended up switching things to help people. So for example, we started on, these are things that come up in any environment, but we started on a kind of conference room with like a big computer set up with a big screen. We ended up switching to an iPad. We sent them an iPad because it was just a little more personable and closer to the patient. They had a little more control over it. And so I think it was like less sort of intimidating. So we made some adjustments. We improved the sound quality. These are all things that we want to be really responsive to. Did you experience technical difficulties? Generally, we really didn't have much of the technical difficulties. We're lucky too in Lewistown, even though it's not an urban by any means, it's a relatively remote location. Their internet connection is very good. Now, in terms of the staff, just to review quickly what the staff satisfaction surveys. So similar Likert scale, where we wanted to ask the staff in similar ways what they thought. Ease of use and learnability. And that dark blue on the left is that very satisfied. The orange is the satisfied. And so overall, people, this was also pleasant, sort of. I'm not surprised, but a kind of good news is, a lot of times adopting new technology is challenging, and we recognize that. And luckily, that all went pretty well. The interface quality, again, mostly satisfied with that. Pretty simple. We really just use mainly Zoom conferencing on an iPad, so it's pretty straightforward, easy to set up. Interaction quality, also no big surprises there. More people neutral about that, I think. And so here's a pop-up question for everyone. Do you feel you have adequate resources, tools, and knowledge in starting or implementing a quality improvement process within your facility? Go ahead and submit. We'll see that answer in a moment. Interaction quality, again, in person, we're finding it kind of balancing out, similar to what the patients thought. Reliability, not having major issues with the system overall. We really haven't had too many issues. Here we go. Do you feel you have adequate resources? And 46% say yes. And so we would love to hear from those of you that said no or are unsure, just to kind of understand better what we can do to provide those. Because I think, in an ideal world, quality improvement, we want to be accessible to everybody, every single person, under that roof. Satisfaction, and then so that gives you kind of a quick overview. This was again a project that had us set up for success in the first place because we weren't being forced. We were sought out by the nursing care center. They're very motivated there, which is wonderful for quality improvement, and so it makes things certainly easier. You may be working somewhere where you say, I'm not sure what the environment is, but there are ways to approach whatever environment you're in. And so you might be learning all about trauma-informed care right now, and you might be thinking, well, how do I implement that? We're gonna talk a little bit about some small steps you can take now, lessons learned from that nursing care center, and what we're doing now as next steps to follow up on that. And these are all things I'm hoping everyone can do. How comfortable are you? Here's another pop-up. How comfortable are you with your understanding of current quality metrics within your facility? So how well do you guys know what your facility tracks, what your managers kind of want to know? Go ahead and submit that. We'll see that pop up in a moment. So the nursing care center is an interesting place. And I kind of want to hear from people in terms of, do you have lots of dementia patients that you work with? Nursing care center, actually, the average age is in the 50s. It's a little bit younger because these are, some of the people that have been institutionalized a long time. Some people have Huntington's. Here's the answer to this last question. How comfortable are you with understanding of quality metrics? And so pretty good. About, let's see, almost 60% are somewhat or very comfortable, and then a chunk are neutral and a little comfortable. So good. So Lewistown is interesting for that reason because we have some of these earlier onset issues. So we actually have quite a few patients that are on the younger end. And so part of what we want to do, we wanted to follow up with was, okay, we started doing some initial quality metric tracking. Well, what else can we do? One of the things that really is universal at a place like Lewistown is some challenges with thinking, whether that's memory, that may be driven by really, really bad, chronic schizophrenia. That may be driven by, something like dementia. There's a lot of overlap there. So we asked ourselves, well, how do we screen and identify it, and what do we do about it? We will be talking about dementia specifically in one of the future talks, but just to sort of give as an example, something we can work on in person ourselves now. I brought up, this technology I've been working on since my background is engineering. Part of my quality improvement hat when I wear it is thinking about technology and how to use that to improve care. And so that's where the software I've been working on came into play. And so one thing we wanted to do was we were thinking, how do we measure a nursing home residence? And this actually really started during COVID. So that not without having to come into the clinic, how do we measure someone's cognition remotely? And so over the years, there's neuropsychology testing, which some of you may be familiar with, and please let me know if you're not, I'll tell you more about it. But traditional neuropsychology testing, takes a full day, can be very hard to find. If you're in a remote location, you may be driving hours to get to it, but it's a big deal to do it. And often the wait time can be months. Even where I work, part-time in Seattle at the hospital setting at University of Washington, our wait time can be 6 months. It's quite a long wait time. There's a big line for it. So one thing I want to know is how do I do a quick, a check? And that's something a little more substantial than a MOCA or a SLUMS or an MMSC, if you guys are familiar with that. some screening tools. So there are these computerized cognitive tests out there. There's quite a few. BrainCheck is by no means the only one, but we went ahead and tried it out. And you can see it's kind of a gamified version of cognitive tests, and it works right on the iPad. And we had the patients do it. On the right is it's a fake made up patient result, just so you can see, but that's somebody who has a pattern of like early stage Alzheimer's disease is this kind of pattern. And so without getting into the details now, the point of this was this really helped us gather some data that we could act on. And so this gives us, in 15 minutes, we could have patients take this test, and then I get the results and I see that report that's on the right, and I can do something about it. So in this case where I'm saying, oh, I think, this is, signs are pointing towards maybe something like Alzheimer's, I'm going to move towards a care model that can support someone with that issue. And so wherever you're located, you guys, and depending on what your interests are, quality improvement and trauma-informed care interventions can involve various different things. So support groups or educational events. Remember, it's really important, and especially as soon as we have hopefully a vaccine and staff are protected and we can get back out into the environment without worrying about COVID. Before, when things were running a little bit more smoothly before this started, we had a lot of reliance on our community. We had tons of community events. And this is, anywhere you are, there's likely some sort of community events. Lewistown is extremely independent and very resourceful because they're located in a relatively remote location. But even doing some of this under your roof, you may just think that, okay, I have some patients that have a history of adverse childhood experiences, history of childhood trauma, like having an art class, looking at art together online even, or having some art books, things like that, looking at nature. Honestly, wherever you are now, even though, and I know different restrictions are challenging right now, but getting outside and going for a walk, the more fresh air, the more sort of nature, people can get, that will really open up for a lot of people and make them feel more comfortable. So there are different programs you can build around using these tools to really make it kind of a consistent and scheduled part of someone's day to have a really positive impact on their life. So these are just some examples of programs out there that have tons of local chapters, whatnot, that we use. So I've taken patients to the art museums. This was before COVID, so a little asterisk on what I'm saying here. We've had to be more creative with some online things, which of course is not as ideal, but we've done art classes ourselves. I've taken, patient groups from residential facilities to ropes courses for all abilities. We've gone to garden walks. Really, it's really just implementing what can be helpful and what can really improve quality of life. And also, open the door, because for somebody that has a history of trauma, they may not feel comfortable communicating in the traditional, language that we use, right? They might feel more comfortable communicating with art, with sharing an experience, and that's really what this is all about, is figuring out what's helpful for that person. Finding local resources, if you're also remote and you have a hard time thinking of opportunities, you can call around, calling local churches, religious institutions often have really strong networks and can be helpful. And the person doesn't even have to be, the patient doesn't have to be religious necessarily, right? These are all, the vast majority of the time, my experience is very positive. They're very helpful across the board. Talking to their primary care, talking to other city officials, city offices, and saying, letting them know that there's a need. If you're working at a nursing home, chances are, you're a major part of the community there. You're housing a number of people that are part of the community, so that the leadership of that community should know that you're there and be able to offer help. Of course, the internet and library and whatnot. If you're lucky enough to have an Alzheimer's Association or something similar like American Parkinson's disease or Lewy body dementia, there's a lot of those for various diseases. NAMI is wonderful for mental health. If you have a local chapter, have local events, they often have nice full calendars with lots of options. I'm listing these as examples, keep in mind, so that each of you feel that there's something you could potentially bring back and think about how to use trauma-informed care and help with something that you might be motivated. It might start with one patient and it might turn into something more substantial, but something that hopefully doesn't feel too much of a burden, doesn't feel like requires a lot of time, and is enjoyable. Managing difficult communication with care providers. Some of your quality improvement interventions might be as simple as starting here. So you might be the one to help mediate with the various interactions your patient, if you're someone that knows your patient well or your resident well, you might be the one mediating. They might have tons of interactions, tons of contacts. It may be overwhelming, and you may be a source of kind of calm and kind of the sort of safety for them. And so being able to communicate things that might not seem positive, or information that they need to digest or make a decision on, and being able to be that mediator, that can be really, really helpful. Of course, there's people that professionally help with that too, so you don't have to take that on, but that's something that a lot of us can do. That's something that I end up doing, even though end up being on the physician side of things. I might limit it, but I've really fought to have longer visits with patients so that I can actually get into some of this, because it's so much of the value. I'd spend as little time as possible on medications and as much time talking about their day-to-day and what they're really spending their time doing. Last few slides I wanted to go over just to kind of try to give some ideas, and I want to hear from some of you regarding this. This was a study that was done with a decent chunk of people, 1,200 people. And what the point was they were doing some things that we all have access to and seeing what the impact was on cognition. How did people's cognitions respond to things like meditation, social activities, nutritional guidance, things like that? And so this one was impressive in that it had a good participation. So only 12% dropout rate. So pretty good. Then they did sort of before and after cognitive screening tests. And this is something you could do as a quality improvement, in your own facility with a simple screening test, that doesn't cost anything. Mayo Clinic's version of this, they have these 10-day brain camps. They have various components, as you can see here, yoga, physical activity, memory training, support groups, wellness education. And then they did this booster session 6 months later. And then at University of Washington, when I was there, Chris Rhodes, who's runs a neuropsychology group there, who's outstanding advocate for patients, he's implemented his own version of this. And so they do 6 to 9 sessions, and they'll do this exercise, meditation, support groups, cognitive rehab, and education. And let me go back to here. And so you can see in the upper right-hand corner, the response to this. And so over time, quite a nice response in terms of cognitive symptoms and cognitive screening tool measurement. And so there was a kind of a significant difference. And overall, though, even more than that, it was nice that it was measured, but people really enjoyed it. It's overall was very beneficial. And so one thing, again, this is to help you think of ways. These are all concrete ways to connect with a patient, with or without trauma in their past. But as we know, with such a high rate of adverse childhood experiences and trauma in the population that you may be treating, it's safe to bet that there is something, and it's safe to bet that there are some activities, there are ways to engage and interact. And the more we do this kind of work, we find the less we need medications, the less we need other types of interventions. And that's not to say that when we use medications, that's a failure. They're there because the reality is, we can't have an ideal situation, but there's always more that we can likely do as a team together to help patients, feel more comfortable and communicate. So that's a bit review of, the second session out of this 10-session series was really meant to go over this real world study. What were some ways that we decided to look at some quality improvement metrics in a nursing home in Montana, and what were the results? And then what are some other ways we're following up? So that it's all about this cycle, right? We're trying to do one cycle, put it into place and then move on. And so we're constantly trying to pick something to improve on. You want to do one thing at a time and it can be a you can think of a very, very small thing. It does not have to be anything substantial. It's better that everybody is involved and participates and does something to improve, care than to try to take on, something enormous that's stressful. So with that being said, those were the slides I had for today. I'm just going to stop the share so I can actually see you guys. Can anyone tell me a little bit about, where they work and some of those questions that we answered earlier in terms of comfort with quality metrics or quality improvement? And let me know if you understand what I'm trying to get at here, because quality improvement sometimes feels like this very opaque or difficult concept, and we want to make it's actually can be very, very simple. Someone say something or I'm gonna poke on you.
I don't see any questions in the chat yet either. And I'll just remind people you can unmute yourself.
Yeah, definitely unmute yourself and say it verbally if you can.
Mm-hmm.
Hi, can you hear me?
Yep, just barely. You're kind of muffled a little bit.
Okay, I'll try. I'm the new long-term care social worker in Ethel, Alaska, very remote. The COVID has really impacted us. Every other week, one of our units is on isolation. We test twice a week, and I'm learning a lot about the culture. In addition to the way, I guess, they express different cognitive impairments. I am new to all that, but I feel there's a lot of support here.
Mm-hmm.
And I feel like I could implement a lot of the suggestions.
Mm-hmm.
I just feel a little uncomfortable. I don't feel confident.
Mm-hmm. So this is a, and I can repeat just so everyone can understand it. So Erica, it sounds like you're working at a nursing home in Alaska, you said, and
Yeah.
You're in a place where, of course, like many of us, COVID has just really had a huge impact. A lot of isolation, a lot of unit closures, and that you haven't previously implemented sort of, quote unquote quality improvement, but you feel a little bit maybe like you don't have the right tools or just you lack the confidence to jump in and do quality improvement. Is that right?
Yes, I feel the facility, the administrator, nursing staff 100% support me.
Mm.
And I feel like there's a lot of tools. It's very person-centered here. And we were seeing a lot of improvements even just when I started. But now with the testing and people coming in and the lockdowns, we're noticing a lot of patients that have declined cognitively.
Right.
But we did implement the telehealth with the psychiatry and the gradual, everything that you presented. And that's what was really working really great here. But now that that's not new, I feel like what you presented today would be great if I could do that the next step because of the decline. But I feel like it's very relevant what you presented today.
Got it. And so one thing I ask myself, Erica, when I'm thinking like, okay, it's such a crazy environment where a lot of us are under stress because we've all been working short staffed because people have been just getting sick all year. And so it can feel like time is of the essence. What I often ask myself is, well, what can I measure? What's something that we can do, but also see the results of so that we can learn and do this cycle? Because often we'll say, oh, let's start like an art class for everybody and jump in. Well, people, that overall is probably going to be good, but in order to make it sustainable and get resources and support, we want to make sure we're doing something where we can measure an impact. And so in your case, where you're noticing, and this is actually nationally, unfortunately, the death rate from dementia has more than doubled since the same time a year ago because of COVID, and not because directly from getting COVID. We're talking about from the social isolation. That's going to be the topic of a future TikTok, things like that. So the indirect effects. And so in intervention, one of the interventions that you may have liked or appreciated is something to do providing an increased feeling of social connection for patients. And so that might involve doing a quick screening tool for the patients there, cognitive screening tool, and then being able to do it, time point now, and then in a month or in 2 months or in 3 months, it's really whatever you think, but measuring a before and after, and also trying to implement something like, oh, we're going to do, at least while COVID is going on, an online group, or if it can be in person because everyone's quarantined together, then great. But finding that one thing, and it might be even just a 5-minute intervention. It does not have to be a huge thing, but that could be some way you could start. Does that answer your question, or Eric? I'm trying to.
No, 100%. It actually, I have a stack of photocopied ideas related to my administrator. Thought that if we related to the villages that people came from, if I could try and get some history. So I have some ideas. So it's actually interesting that it's right on point, and I feel a lot better. Thank you.
Good.
I feel excited. Thank you.
No, I'm glad. Anyone else with any experiences, either struggling to get, a quality improvement project? And again, we're using the quality improvement. Don't be intimidated by that term. Trauma-informed care within your setting, doing something to improve in any way, any kind of improvement. Could be smallest thing counts. Anybody else? Yeah, absolutely, Eric. I will keep you posted.
Oh, no, Reza, hey, this is Eric. I was just saying, I'm wondering if Erica can keep us posted on her progress.
Oh, nice.
In terms of, getting, maybe starting something, be interesting to see what the initiative is, how she's measuring it, what worked, what didn't work, and then maybe others, in this community might be interested in doing something like that as well.
You know what? I'll accept the challenge, and I'm going to come up with something, and I'm going to hold myself accountable, because I'm willing to do that for my elders, for my residents. So I will do it for sure. Thank you.
That's wonderful, Erica. Yeah, we really support it. Truly, we would love to hear about that. So that'd be wonderful. And regardless of what happens, bumps in the road will help you get over those. Anyone else? We're kind of at the tail end now, so really just want to hear from the audience and be able to give any direct, help or feedback, or just share a story. It's funny, almost nobody has their cameras on, so it's a very private group.
Actually, Reza, I have a special code here. I can turn on everybody's camera right now. Do you want me to do that?
Nice.
I can't.
3, 2.
I'm kidding, guys. Oh, Renee, looking good. All right.
Nice. No, it's okay. I know some of you don't have cameras and microphones, and no worries. I know we're all doing the best we can. Some of us are probably sitting in a parking lot, trying to join where we can. So we had some of the. Oh, go ahead.
No, I was just saying thank you to both you and Dr. Arzubi to join us today. And again, if you do have questions, please use the chat box, or you can just unmute yourself.
Yeah, and feel free to reach out to me really anytime, because since this will be a series, I would love to have your questions, and I can build them into each subsequent talk, and we'll make sure we cover it. But really, my main goal is to make sure each of you walks away with something that you have, like an idea you have that you feel more empowered to do. So I really want this to be translated into action. And so if you have any questions or anything I can do to help, let me know.
Oh, guys, I wonder, I had a question, Alana. I wonder if maybe as part of the process, maybe right ahead of the next session, maybe prompting and inviting questions for the next round related to anything we've discussed or plan on discussing. How do you feel about that?
Yeah, no, that would be great.
Yeah.
Okay.
And again, that next session is going to be December 16th.
Mm-hmm.
Well, I was going to ask a question. Suggestions maybe on how to identify dementia behaviors that could be related to a previous trauma, but we have no way of validating that. We can make assumptions, but not really pinning it down.
Right. Great question, Joanne. What I find in practice is that regardless of a stage of life, and so when I'm talking to my patients that have dementia, the coping skills, so the behaviors that tend to come out, tend to have roots, earlier in their life. So, for example, as you get older, we often use the term sundowning. And so people say, oh, I used to it runs in the family, or, my grandmother, this or that. But that's not as important. What's more important is trying to look at specific behaviors. So let's say the something in particular is upsetting. It's usually something that's identifiable. So let's say the patient really hates getting their hair brushed, or that, every time I try to approach them to go to the bathroom or whatever it might be, being able to identify the specific trigger, which there almost always is, can really help then start the conversation. And again, with somebody with dementia, you may not be able to have a conversation like we're having now, but it may be just changing the approach and approaching them with a different action to try to mix things up. So we often do it with kids really easily, with which Dr. Arzubi has more experience with. For example, when kids come in for their shots, we do like all kinds of funny behaviors and distractions and things like that. And those are some of the things that we end up actually wanting to do with those with dementia or cognitive decline, because because they're an adult, we talk to them like, oh, logical, here, it's time to go to the bathroom, let's go to the bathroom. And that just doesn't sometimes sit well. And it very well may be an underlying trauma driving that. And so thinking of, well, how can I approach it differently? Introducing some humor as much as possible, finding that no matter how advanced once the dementia is very advanced, it can be challenging, but there is that point. But really with even my patients with early and moderate stage dementias, I'm able to find some of that common ground, if that makes sense.
That does. Yeah, even like having some more suggestions or examples might be very helpful to a lot of us.
Absolutely. And when I think in 2 talks, we'll be more specifically honing in on dementia. And so I'll make a note to give more examples and to kind of give some anecdotes about what we do in the dementia world.
That'd be great. Thank you.
Great. Thank you.
Anybody else have any other questions? We have just a few more minutes. Can we get
Can
a
I just
syllabus?
can I just ask a question about in starting to think about what I want to implement? What tools am I going to use to measure, like the pre and post? Do I have to come up with the questions on my own, or is there something online, or I just do a regular cognitive assessment before and after? Like, is there a suggestion for that?
Right. No, good question. If you're really focusing on cognitive outcomes, to keep it simplest, you could start with a screening tool like the MoCA or MMSE or SLUMS. Those are the 3 most common ones. The St. Louis, SLUMS is the St. Louis one that came out of the VA down there. And then MoCA is the Montreal one. That's, I think, kind of most popular. And then mini mental status exam is an old one. So those are kind of 3 common cognitive ones. Those are just easier. They're quick. They're in person. You can print them off online. So that's one tool you could use. You could also just do a subset. You could do a mini cog. You could do like a clock drawing and like a mini trails B, the 1A, 2B, and you could have like a 5-word recall. So you can kind of make up your own too. I mean, it's really thinking about what are you trying to track. If you want to see if they're going to get better over the next 6 months, you might have to do a little bit more. If you're thinking they're going to, you want to see if they're going to get better in 1 month, you may have to do, you might be able to do a little less testing, depending on where the starting point is. Just you kind of have to use your judgment with who your crowd is and how much you expect a change to be. So then that's how you know how much you need to measure. But it's not a perfect science, but that's kind of one way to start.
Can it be even just like, okay, a little mini mental? I could do any one of the ones you recommended, but can it even be just an increased willingness to participate?
Yeah, no, I mean, yeah, so that you use like the scales we used at Lewistown, where we do kind of on a scale of 1 to 5 and have some feedback from patients and the staff. So you can kind of get both perspectives. Like, is this patient more willing? Does the patient feel more willing? That's a completely valid way to go too.
Thanks, got it.
Yep.
And Rez, I just had one quick thought also is when you're capturing those things, it might be good to capture. So for example, if you're doing like a scale of 1 to 5, in terms of the person's willingness to do something at that moment, I wonder if maybe considering saying, hey, in the last, I don't know, last 3 days or in the last week, what has that person's willingness been to do certain, follow certain requests? Just because, right, I mean, especially it happens with kids, but also as with adults, especially folks in nursing homes, there's such a swing in functioning depending on the day. So just kind of getting an average might be helpful. How do you feel about that, Reza?
Yeah, I like that. I mean, it's probably best to, think about the previous week or the previous, couple weeks, depending on how often. That way you also don't have to ask them so often, kind of average together, make it easier to do. Awesome. Anything else? Next time, I'm going to challenge some of you, at least the ones that have the capability to share your video as well, so I can see how well my jokes are going.
Well, I was smiling most of the time, so you did great. Thank you all for joining today. Again, this webinar is recorded. We will post it on our Mountain Pacific website. And for those of you who are obtaining nursing contact hours, if you don't get something from me by the end of next week, please email me. Again, my email address, I put it in chat, but it's AJARMIN, excuse me, @mpqhf.org. Thank you all for joining today, and thank you, Dr. Gomi, and thank you, Dr. Azubi.
Thank you all. Yep.
You're welcome.
See you in a
Thank you.
couple weeks.